Welcome to our next segment, and welcome back to our panel. In this section, we're going to touch on maintenance therapy, and we're going to go around the panel here and ask them what is their preferred regimen for maintenance therapy post-transplant for transplant-eligible, standard risk, and high-risk disease. So, Sasha, I will start with you again. What's your favorite regimen for standard risk, high risk, post-transplant maintenance?
Standard risk is typically lenalidomide. I think it's probably the most well-proven and beneficial agent. Long history, a long track record. For high-risk patients, I kind of waffle between lenalidomide and bortezomib based on AJ's data that Emory published years ago, but based on Griffin, I think it's also very reasonable to do lenalidomide. Probably these days, I'm more often doing lenalidomide only because it's easier to tolerate than the bortezomib, but I think either lenalidomide or lenalidomide bortezomib are perfectly fair for the high-risk patients.
Ajay, what is your preferred maintenance, and has the Auriga study that was presented at IMS altered your practice?
This is a great question. So you ask 10 people, you get 50 different opinions, I believe. So the way that we have historically seen was standard risk patients and high risk patients. But we start to understand more about the flavors of myeloma, and 10% of all myeloma patients, they behave like extremely aggressive. This is the ultra high risk group. So I think we should start to see them as 3 different groups rather than 2 different groups. More is better. So there's no doubt, just like Sasha said, like that standard risk group, yes, you can get better PFS based on the Forte trial, based on every trial that uses a combination maintenance better than the len maintenance. However, do these standard risk patients really need that combination maintenance over a longer period? So we all agree that probably we can get away with getting a good PFS benefit with giving just the len maintenance. But if you look at the ultra high risk group, so which is the other extreme, we probably might need more than the PI and the IMID. So that's where the GMMG concept study has given, and the master trial has given us really good insights, as well as a MUC9 trial. All these saying that you have to combine the PI, IMID, and a CD38 antibody, potentially not allowing these patients to relapse. That should be the real goal of this ultra high risk patients. So now, in the middle are the high-risk patients, where historically what we have called them, grouped all of the high-risk patients together. So if you can tease out those patients that had one high-risk abnormality, they had done considerably well with the PI plus IMID regimen. And if somebody has not received a prior anti-CD38 antibody, using a combination with an IMID plus a anti-CD38 antibody probably is how I would approach this specific patient population. The Auriga trial has clearly shown this. Among those patients that have not received a prior anti-CD38 antibody, combining dara plus len in this specific patient population increased the MRD negativity rate significantly. And that is the data that I used to make this decision. Also, the Cassiopeia, the arm that did not receive any daratumumab before in the induction setting, getting the benefit in the maintenance setting probably allows me to make the decision as well.
So, Sham, what is your maintenance strategy? Has Auriga impacted your maintenance?
Because of the previous section where we said most of our patients are getting quadruplets, I guess Auriga does not really inform what to do with that setting. So unfortunately, maybe does not have a great impact on my practice at this point. But I also think that the maintenance question is probably the most difficult question for patients and doctors with newly diagnosed myeloma for a few reasons. I think maintenance, we're by definition more and more with the use of quadruplets, we're taking patients with very deep responses already and asking them to take continuous treatments to keep their disease under control. I agree with Sasha that lenalidomide is the standard of care for my practice as well for newly diagnosed myeloma. I'll make one point, though. All the data we have for lenalidomide comes from the triplet era, not the quadruplet era. So we're extrapolating. There is clearly survival benefit to using lenalidomide 2 years or indefinitely in the context of using triplets, similar to the Origa study, where there was triplets or predominantly triplets followed by Darolan maintenance. We're now extrapolating that to long-term follow-up. It is the standard until otherwise shown, I think, for standard risk myeloma patients. I think the two caveats there are that we're using this in the quadruplet era, where patients are getting quadruplet therapy. The second is there are some real serious side effects with long-term use of lenalidomide, one of which is, I guess, the risk of secondary cancer. So I do think as a field, we should start to define what duration of treatments do patients with standard risk myeloma need. Is it 2 years? Is it 3 years? Is it 5 years? Is it indefinite? Studies like Myeloma 11 maybe give us some inkling of the ideal duration, but I think we do need some randomized data that would hopefully allow us to safely discontinue maintenance for patients that do not need extended period of maintenance in standard risk population. The last point I would make there is most of the benefit now, with the exception of lenalidomide, is PFS benefit. And one can argue, is that sufficient to change practice for maintenance? For instance, if you're using 2 drugs as maintenance continuously, and you may very well see a PFS benefit, but then you're probably not going to get much benefit from CD38 antibody or a PI you're using as maintenance in the second or third line setting. So in the long run, does that PFS benefit offset the downside that you were not able to maybe get the same benefit with the second or third line use of these classes of drugs is also unclear. So I think the standard risk myeloma single drug maintenance to me is what I do mostly, but also being mindful that we need to start thinking about patients who are in very deep responses. Can we stop maintenance, etc. High risk, very complex. I guess there are truly high risk patients who, unfortunately, I do not think benefit from any of these maintenance approaches, and those are patients that we would need to come up with novel or different strategies. I don't think just continuing the existing drugs allows us to provide long PFS even in those ultra high risk, or as Ajay said, there are 10% of patients who have multiple cytogenetic abnormalities, other high risk factors. So in those patients, yes, we do doublet or I guess, as Ajay said, sometimes triplet maintenance. But again, understanding significant limitations that these patients don't tend to do well with traditional treatments of all 3 classes of drugs, and perhaps should be, when available, considered for clinical trials of novel treatments. In the patients with one high risk feature, I think a doublet maintenance, as Sasha and Ajay mentioned, is a reasonable approach.
Melissa, what is your approach? Any
Yeah,
different?
no, very similar, but we incorporate also like a response adapted approach. Like if I have a standard risk patient, 3 months post-transplant is not in CR, I would give that patient consolidation, try to get him on a deeper response before I go to my lenalidomide maintenance. If the patient is high risk, we do double maintenance, more commonly with a PI and an IMiD. Origa doesn't change too much. It's the majority of the patients that we're seeing now, number 1, has received CD38 as part of the induction. But I mean, it's helpful in the sense, using this response adapted approach, right? If you have a patient that is still MRD positive or is not in CR 3 months post-transplant, I think those patients need more than just Revlimid maintenance. And I agree with Sham, the patients that have, ultra high risk myeloma, those patients are very hard. They still remain a challenge. I mean, I would still push it to try to get them into MRD negativity, but I think the best choice for this patient is more novel therapies, CAR-T, upfront clinical trials.
I would agree with everything that's been said, and I would also agree that this is a very complicated topic, but we are in a better place than ever before. I don't make changes on the basis of the MRD status yet. We are waiting for certain trials to result out. Specifically, I'd like to point out about an ongoing study, the dramatic trial S1803, that is looking at patients post-transplant and randomizing them to lenalidomide alone or lenalidomide plus daratumumab. And the patients are to continue lenalidomide or len plus dara maintenance for 2 years. And if they are MRD negative and randomized to len arm, then they can either stop or continue, and they'll be randomized there. And if they are MRD positive, depending on whatever arm they are randomized to, they would continue with that treatment. That is a very important study that's still ongoing, and it's a large study. It's a national study. I would put in a plug for that, although I'm not directly involved with the study. I think that will answer a lot of questions. It is also important to point out trials such as the Perseus trial, for instance. they have not looked at re-randomization at the time of maintenance. So they have looked at a schema of treatment, and that schema has an induction phase, the transplant phase, the post-transplant consolidation phase, followed by maintenance phase. So it's comparing one entire schema to another entire schema, which was, again, looking at daratumumab incorporation all through versus no daratumumab all through and len alone maintenance. So that complicates the picture because we are not able to isolate the effect of DARA in the setting of maintenance there, whether all the impact of improved PFS, improved MRD negativity rates, was it purely induction and transplant related or maintenance related as well? What we do know is that over time with maintenance, there is significant reduction in the MRD positive rates, more so in the doublet such as DARA Rev arm compared to Rev from the time when patients were starting their maintenance. So clearly doublet appears to be, Auriga, as already has been stated, is only for a specific subgroup of patients who were MRD positive, so it doesn't apply to MRD negative, and the patients have to be DARA naive to apply that data. And in my practice, just as Sham indicated, I use lenalidomide in standard risk based on Ajay's very impressive data that has been using bortezomib in combination with lenalidomide in high risk that has also been backed up subsequently in the subsequent Emory study by Dr. Joseph. I think for high risk, we definitely need at least an IMiD and a PI. And for standard risk, for now, my approach is to use lenalidomide alone until progression. We don't know about what the optimal duration of maintenance treatment is. And as far as the MRD adaptive approach goes, Ajay did bring up a very important point about standard risk patients. What we don't know is sometimes when the standard risk patients don't respond, they do behave like high risk. And there has to be a dynamic risk stratification as well. And that's what hopefully MIDA study eventually will be able to shed light upon.
This has been a great discussion about the data and how we use this data and guidelines to care for patients. We will explore in the next segment. Thank you.